Welcome back to Open Med School. Today I am going to discuss with you Internal Medicine 1.1, that is the epidemiology, pathogenesis, clinical evolution and course of common heart diseases, that is rheumatic, ischemic, cardiomyopathy and inflammatory disease of the heart. First, let us take rheumatic heart disease. This is usually called rheumatic valvular heart disease. Rheumatic heart disease predominantly affects people in the developing countries. This is due to an abnormal immune response to group A beta hemolytic streptococcal. Beta hemolytic streptococcal produces sore throat. Repeated episodes of acute rheumatic fever can occur following sore throat. That is, antibodies produced against the beta hemolytic streptococcal has got molecular mimicry with the cardiac antigens. So these antibodies will react to heart muscles and lead on to inflammation and scarring of the heart walls. This actually produces a pancreatitis, that is, it affects the myocardium, pericardium and valves. But the predominant involvement is in the scarring of the valves. The most common affected valve is mitral, followed by aortic. Sometimes we can get combination of mitral and aortic valves. This can produce both stenosis, that is narrowing, or difficulty in closing the valves, that is the incomplete closure, otherwise called the incompetence. So you can get mitral stenosis, mitral regurgitation. Aortic stenosis, aortic regurgitation. Very rarely tricuspid valve and pulmonic valves are affected. Initially, patients might not exhibit any symptoms. As the disease progresses, the patient develops features of heart failure, that is breathlessness. They can have palpitation, fatigue and other manifestations. Without proper treatment, rheumatic heart disease can lead on to complications like heart failure. Most important dreaded complication is development of infective endocarditis. That is, bacteria will get attached to these valves and produce some vegetations there. They grow there and get embolized, and that can lead on to stroke also. Valve damage may necessitate surgical intervention like valve replacement or repair. The details we will study in later sessions. So here you can see the acute pharyngitis that is being produced by the beta hemolytic streptococcal. This mounts an immune reaction that attacks the heart muscle that due to the molecular mimicry about which I have already discussed with you. The acute rheumatic fever is diagnosed by the modified Jones criteria, which has got a major criteria and minor criteria. The major criteria are pancreatitis, polyarthritis, Sydenham's chorea, subcutaneous nodules and erythema marginatum. Minor criteria: fever, arthralgia, prolonged PR interval, increased acute phase reactants like ESR and CRP, and leukocytosis. For a diagnosis of rheumatic fever requires two major or one major plus two minor. And there should be evidence of streptococcal infection, that is mandatory. In addition to this, there should be evidence of streptococcal infection like sore throat, from the which you should get a positive culture. Other details we will study in next sessions. So here we can see the sore throat producing tonsillitis or pharyngitis, which leads on to the formation of antibodies that react against the heart and produces pancreatitis. And the pathology you will study in next sessions. Then in the myocardium there is what is called development of Aschoff bodies. And here you can see the valves which get damaged later. Now we go to the second condition, the ischemic heart disease. Ischemic heart disease is one of the leading cause of death worldwide. It is more common in the elderly. And there are modifiable risk factors like hypertension, diabetes, smoking and dyslipidemia, and unmodifiable risk factors like age, sex, ethnicity, etc. The major pathogenesis is coronary artery blockage. This blockage is due to narrowing of the coronary arteries due to atherosclerosis. The atherosclerosis restricts the blood flow to the heart muscle, leading to ischemia and potential myocardial infarction, cause heart attack at a later time. And the pain due to this decreased blood flow to the heart is called angina pectoris. There are different types of angina that occurs during exertion. Is a stable angina, there is unstable angina, and the prolonged ischemia due to complete obstruction of blood vessel leads on to necrosis of the heart muscle, that is called myocardial infarction. Symptoms of ischemic heart disease can vary from chest pain on exertion, that is angina. Patient can develop features of heart failure, breathlessness, fatigue, dizziness. Again, the symptomatology varies. If left untreated, ischemic heart disease can lead to complications such as myocardial infarction, can produce arrhythmias, heart failure, and even sudden death. Treatment involves lifestyle modification, medication, revascularization procedures like angioplasty and bypass, or even coronary artery bypass surgery, and rehabilitation. So, in angina, usually the pain is a visceral pain, so the patient will show a diffuse pain, and sometimes it is of the size of the fist, and this sign is called the Levin sign. So here you can see the patient sitting with the pain, showing the pain. Then comes the cardiomyopathy. Cardiomyopathies are diseases of the myocardium. There are different types of cardiomyopathy, classically divided into the dilated cardiomyopathy, hypertrophic cardiomyopathy. Other cardiomyopathies are there. One is the arrhythmogenic right ventricular cardiomyopathy, that is, this produces arrhythmias. Then restrictive cardiomyopathy. So these are the major cardiomyopathies: hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, and restrictive cardiomyopathy. So epidemiologically, hypertrophic cardiomyopathy is relatively a common genetic heart disease. This prevalence varies across populations. It can affect individuals of any age. It is characterized by, that is, hypertrophic cardiomyopathy, otherwise called HOCM or HOCM or HCM, abnormal thickening, that is, hypertrophy of the heart muscles. Particularly, it affects the left ventricle without any obvious cause. Hypertension can produce thickening of the heart. That is a little different from this hypertrophic cardiomyopathy. It is often an inherited disease and can result from mutations in the genes encoding proteins of the cardiac muscle. Clinical evolution, the symptoms include chest pain, shortness of breath, palpitation, can produce fainting. Some individuals may develop sudden death also. So they can be asymptomatic also. As mentioned, HCM can lead on to complications such as heart failure, arrhythmias, including sudden death and stroke. Treatment aims to relieve the symptoms, prevent complications, and reduce the risk of sudden death. Lifestyle changes, and in some cases, surgical intervention. It's not. So here you can see the cardiac muscle, which is unusually hypertrophied. Then coming to the inflammatory heart disease. Inflammatory heart disease encompasses range of conditions including myocarditis and pericarditis. Endocarditis we already mentioned, and in some diseases like rheumatic fever, it produces a pancarditis. Sometimes pericardium alone, especially in viral diseases, you can get a pericarditis. Tuberculosis can produce pericarditis. Myocarditis can occur in viral infections. Classically, we have studied about the COVID disease. COVID can produce myocarditis. Many drugs can produce, especially adriamycin, many chemotherapeutic agents. So drugs can also produce myocarditis. Inflammatory heart disease involving the inflammation of the or producing inflammation of the heart muscle result from viral, bacterial, and autoimmune conditions. For example, systemic lupus erythematosus. And in many systemic inflammatory conditions also you can get. Symptoms can include chest pain. The patient with myocarditis can lead on to heart failure, so they present with breathlessness, can have fever, fatigue, palpitations. In some cases, when there is evidence of pericarditis, we can get pain which is suggestive of a pericarditis. And pericarditis can lead on to accumulation of fluid in the pericardial cavity, that can lead on to cardiac tamponade. Tamponade is restriction of the filling of the heart due to something in the pericardium. So fluid in the pericardium can restrict the myocardial filling. The course of inflammatory heart disease depends upon the underlying cause and severity of inflammation. Mild cases like viral, they spontaneously recover. Severe cases may lead to complications such as heart failure, arrhythmias, cardiogenic shock. Treatment depends upon the underlying cause. Systemic disease like renal failure can produce what is called a uremic pericarditis. So, two pericarditis you should remember: one is viral, second is tuberculous, third is drugs for this. Acute rheumatic fever we have already mentioned, and then systemic disease like uremia, that is renal failure. So, here it shows the pericardial cavity containing the pericardial effusion. So, we have discussed the epidemiology, pathogenesis, and clinical evolution of the common heart diseases. And in the next sessions, we will study about the details of this. Whatever be the etiology of the heart disease usually produces the symptoms which are fairly common. The symptoms are: one is chest pain, second is breathlessness, third is palpitation. For this, you can develop dizziness, and sometimes you may get a dependent edema, that pedal edema. Edema can be symptom versus sign. So, any patient with heart disease, you have to ask about these symptoms. Hope this was useful to you. Thank you.